All right, so again, welcome to Smilow Cares. My name is Jenna Addison. I'm a nurse practitioner here at the breast center here in the Smilow Bridgeport Hospital area. I'm going to talk a little bit today about breast cancer risk, average risk, high risk, and how we manage it. So, when we talk about risk and risk of developing breast cancer, who is at risk? And the short answer is anyone who has breast tissue. That's men and women. And when we talk about average risk, it's about 13% over a woman's lifetime that she has a chance of developing breast cancer. And that's significant. For men, and men do develop breast cancer, it's much less, 0.13% over their lifetime, but it is still a risk. So when we talk about risk, we want to talk about average risk, high risk, what are the recommendations and what we could do. So that's what's average risk. What is high risk? High risk is anyone who has a lifetime risk of developing breast cancer greater than or equal to 20%. I'll talk in a little bit about how we get there and how we calculate that. But what are the things that go into determining if someone is average risk or high risk? Personal history, family history, genetic history, and modifiable, non-modifiable risk factors, things that we could change, like our BMI, like our alcohol use, things that we don't have any control over, like our family, like when we get our first period, like when we go into menopause. There's some other things that go into high risk factors, and that's our breast density. When someone goes to get a mammogram, there's often a little blurb saying breast density, and there's 4 different categories. I'm going to talk a little bit about that on the next slide. That absolutely informs our risk. History of an abnormal breast biopsy. So if someone has a non-cancerous breast biopsy, but it shows something like a typical hyperplasia or lobular hyperplasia, that could significantly impact their lifetime risk and how we manage them going forward. And still want to mention, even though it's not as many people that fall into this category, but previous thoracic radiation to the chest for something like a lymphoma, does increase risk later on in life. So I'm going to take a little cul-de-sac into breast density. So as I said, there's 4 categories for breast density, going from least to most dense. And as you see here, it's a big difference from the least dense of fatty replaced breasts to extremely dense breast tissue. And it does inform risk. So not only from a biological standpoint are extremely dense breasts higher risk, but if you see here, it's harder to see things with extremely dense breast tissue. Things that we look for on a mammogram, like calcifications, like densities, like asymmetries of tissue. Sometimes they could be obscured by all that whiteout tissue. So in the most recent guidelines, extremely dense breast tissue is an independent risk factor. So it's important to know what your breast density is and if you need any additional supplemental screening based on that. One other thing to note is that most women, as they age, as they go into menopause, they will lose some breast density. So I have often patients who say, I had dense breast tissue all my life, and now they're telling me my breasts aren't dense anymore. What happened? Most women lose breast density in menopause, so that is normal. That is to be expected. So coming back from the cul-de-sac of breast density, how do you know if you're at higher risk for developing breast cancer? So, you want to think about your extra risk factors other than personal history of breast cancer, significant family history. Do you have a lot of women in your family or any men who have had breast cancer? What are their ages? Have you been tested for a genetic mutation or pathogenic variant and been positive? Personal history of atypical biopsy, prior radiation to the chest for something like a lymphoma or extreme breast density. And then we start looking into, do you need a risk assessment? So this is another kind of infographic about those people who need further assessment. So, we know our high-risk individuals are someone with a known gene mutation, the personal history of atypical biopsy, the personal history of this chest radiation, and we know the average risk, someone who doesn't have a family history, has low density breast tissue, lives an active lifestyle. But those people that fall in the middle, those are the people who need further assessment. So not only a strong family history, especially individuals who are diagnosed earlier than 50 years old, we also look at triple negative breast cancer here as TNBC. It is a more aggressive form of breast cancer that can be associated with a BRCA1 gene mutation. Male breast cancers as well, because they're rare and they can be associated with a gene mutation. Anyone with a family history of that needs further assessment. Ashkenazi Jewish heritage. So 1 in 40 people who are Ashkenazi Jewish, the incidence of a BRCA mutation is 1 in 40. That's significant. So anyone who is Ashkenazi Jewish who has a family history of breast cancer should have genetic testing and should have a further risk assessment. Same thing with Black or African American women, higher incidence of more aggressive types of breast cancer and a higher incidence of mortality from breast cancer. And that is multifactorial. It's not only due to the higher incidence of these aggressive breast cancers, there's also health disparities that go into that. Again, the increased mammographic density and lifestyle risk factors like elevated BMI and alcohol and substance use. So how do we assess this risk? The tool that I like to use is our Tyrer-Cuzick risk assessment. And this is something that takes into account those personal and family risk factors. It also takes into account Ashkenazi inheritance, HRT, hormone replacement therapy use, previous genetic testing, affected cousins, breast density. It's a very comprehensive risk assessment, not perfect, but very comprehensive. And what it tells us is it gives us a 10-year and a lifetime risk of developing breast cancer, as well as a percentage risk of having a BRCA mutation. So if someone is greater than a 20% lifetime risk, we know that they may need supplemental screening. If someone is greater than a 5% 10-year risk, they may need additional risk-reducing agents. I put this picture of Olivia Munn here because she is someone who getting a risk assessment like this, likely could have saved her life. She is someone who I believe is gene negative and had a normal mammogram, had a risk assessment, was found to be high risk, went for an MRI, and that discovered her breast cancer. So she has been an advocate for risk assessment. And she says here that she did have a Tyrer-Cuzick risk assessment score in the 30% range. So I've touched a little bit on genetic risk and genetic testing. So let me go a little bit deeper into that. So what is genetic testing? Why do we do it? What does it show us? So we know that there are cancer susceptibility genes. And if someone has a mutation or a pathogenic variant in a gene, like BRCA, we know that they have a higher lifetime risk of developing certain cancers. They have an inherited risk in their DNA of developing certain cancers. So by identifying that, we could help guide their management. So who needs to be screened for genetics? So first of all, if you have a known gene mutation in your family, you absolutely need to be screened for genetic testing. Additionally, people with a personal history of breast cancer, especially if they are aged under 50, any male breast cancer, anyone who has a personal history in Ashkenazi Jewish heritage, if they have a history of lobular breast cancer with a family history of gastric cancer, there's a gene that that would be concerning for, as well as a significant family history or triple negative breast cancer. So that's people with a personal history of breast cancer. If someone comes in and they have a family history and they're asking whether or not they should be screened for a genetic risk, if you have a first or second degree relative that meets that other criteria, or you have a question about it, ask, be screened to see if you meet guidelines for testing. Even if someone doesn't meet guidelines for testing, but they still have a family history, there are reasonable self-pay options for genetic testing. And like I said, this can guide our screening management, our risk management, and see if there's anything specific that we need to follow as far as guidelines for specific genes. So genetic risk, it's not just BRCA. A lot of times people will say, I'm looking for BRCA testing. I want to get BRCA testing. Gene testing is not just BRCA anymore. And it's all fairly new. BRCA was only identified in the 90s. And the testing that we do now, which is kind of called panel testing or multi-gene testing, has only really been widely used since the mid 2010s. So I also have people who come to see me who had genetic testing many years ago, and it might be out of date. You might need updated testing. I put here some of the other kind of examples of a gene right here. So ATM gene has an increased risk of breast cancer, a little bit of an increased risk of ovarian and pancreatic cancer. So it's not just breast cancer risk if someone were to be positive for these genes. There's other body systems that are affected, and you may change management of screening for other body systems based on genetic testing results. Now, that all to be said, most people that get tested are negative. Positive result, you would need to meet with a genetic counselor to go over management. And what we do about a positive result really has to do with the gene. A lot of the time it's screening. Sometimes it's meeting with other specialists. Sometimes it's talking about risk reducing surgery, but it's not a one size fits all. And it really depends on the gene that we're working with. There's also something called a variant of uncertain significance. So someone gets testing and it says that they have a variant in, let's say, the ATM gene. What that means is someone has a variant in their DNA for that gene, but we don't have enough information to know if it's a normal or abnormal variant. So because of that, we don't change management and we base things based on personal and family risk. And that's true as well of someone who gets genetic testing and is found to be negative. We go back and we base their management and their risk assessment on personal and family risk factors, irregardless of genetics. Obviously positive, it depends on that particular gene. So how do we manage this risk? I love putting things into buckets. So managing risk goes into two buckets, and that is early detection and risk reduction. So again, it is not a one size fits all scenario. This is a holistic, individually based risk assessment where we stratify people: very low risk, intermediate risk, high risk, very high risk. And using personal family history, some of these risk assessment tools, we're able to make a personalized plan. So our first bucket is early detection. Nothing will replace a self-breast exam. I really strongly encourage all women to know their breasts well, to know what's their normal, and to do a self-breast exam monthly. And what you're looking for is anything new or different. Lumps, bumps, skin changes, nipple discharge, something that doesn't feel like anything else around it, doesn't feel like the other side. We would always rather someone come in and it be okay. So if you feel something, if something doesn't seem right, you always want to talk to your clinician and get it evaluated. So both average and high risk women should be doing monthly self-breast exams. The best time to do it, if you're getting a regular period, is the week after your period. If you're postmenopausal or you're not getting a regular period, think about it first of the month. There is a great survivor influencer who has kind of a hashtag, feel them on the first. I think that's great. That's a great way to remind yourself to do a self-breast exam on the first of the month. Clinical breast exam. That's when you see your primary care, your gynecologist, your breast specialist, and they do a physical exam of your breasts. For the average risk woman, that should be around once a year, and of course, as needed for concerns. For higher risk women, that should be at least twice a year. Screening imaging, very important. So our standard imaging is mammography. It's an X-ray. And for the average risk woman, you want to do that every 1 to 2 years or annually, starting at 40, and then as needed for concerns. And that's with or without supplemental dense breast imaging based on your breast density on mammography. For higher risk women, still want to do annual mammogram, starting 10 years younger than the youngest family member diagnosed with breast cancer, but not younger than 30. And I'm going to put a little asterisk right there, not younger than 30, and I'll get back to that in a second. Supplemental screening. This is dense breast screening. This is higher risk screening. So this is currently evolving. The latest guidelines tell us that dense breast tissue is an independent risk factor, and we should be considering screening MRI and screening ultrasound. Currently, we are using ultrasound for dense breast screening. So for a woman with heterogeneously dense breasts, mammogram plus ultrasound for dense breast screening, and then assessing for other risk factors. For breast MRI, that would be for a woman with no other risk factors with extremely dense breast tissue. So that's something that is kind of a newer guideline, and you would want to speak to your clinician about that for extremely dense breasts. For higher risk women or women with a positive gene mutation, depending on the gene, we generally will add screening breast MRI to our screening plan. And that is no radiation. It does use IV contrast. It's looking at enhancement of contrast in the tissue and identifying issues. It's a very sensitive test. It does pick up more cancers than mammogram alone. And it's something that we use in women who have a greater than 20% lifetime risk or extremely dense breast tissue. People who are getting both mammogram and MRI, MRI does not replace mammogram. We generally stagger them about 6 months apart so that you're getting each tested about once a year, but you're getting breast imaging about every 6 months. So, and for higher risk women, that's going to start, again, 10 years younger than the youngest family member diagnosed, not younger than 25 or 40, whatever comes first. Now, my little asterisk about the younger side of that age, if there is a family where breast cancer incidence is very, very young, we make those decisions about starting imaging younger on a case-by-case basis. So again, these are guidelines, but not everyone fits into the guidelines. So case-by-case basis. So our second bucket is risk reduction. So we not only have medication management for risk reduction, we have modifiable risk factors and lifestyle. And a lot of people say, wait, I didn't know I could use a medication to reduce my breast cancer risk. Yes, you can. There are people that this is appropriate for. It's not appropriate for everybody. But if you have a 10-year risk assessed to be greater than 5%, or a personal history of atypia on biopsy or excision. Likely those are the two most common scenarios where someone would qualify for one of these medications. And the goal is to reduce your risk of hormone-positive breast cancer. And drugs like tamoxifen, which we use for breast cancer treatment, are used as a risk reduction agent. And its goal is to block estrogen. So this is a little table talking about risk reduction. Now, for someone with a family history who qualifies for risk-reducing medication, it reduces the risk of a hormone-positive breast cancer by about half. So that's significant risk reduction. And for people with a history of atypical hyperplasia or lobular carcinoma in situ, which even though it has carcinoma in the name, not a cancer, it's a risk, high-risk lesion. It reduces it by more than 50%. So it's significant risk reduction with taking these medications. This is something that you would be assessed to see if you qualify for, and then meet with a breast specialist or medical oncologist to prescribe this medication. Because of course, with any medication, there are risks. With a medication like tamoxifen, there are some rare risks of things like uterine cancer, blood clots. But again, it's an excellent tool for risk reduction if you qualify for it. So what else reduces risk? I often say that the two things I care about the most are obesity and drinking. Beyond that, we got to live our lives in moderation. So we know that postmenopausal obesity, having a high BMI after menopause, is a significant risk factor for developing not only breast cancer, but other cancers. So anything that we could do to avoid obesity or maintain a healthy BMI is going to reduce your breast cancer risk. So the other things that are kind of into that risk reduction: exercise. We want to have 150 to 300 minutes a week of exercise. That's anything that gets your heart rate going. You don't need to sign up for CrossFit. You don't need to run a marathon. Walking at a brisk pace is going to get you there. I would love you to integrate some light weights if that's appropriate for you, but exercise is a great risk reduction tool. So, and eating in moderation. We want to avoid ultra processed meats. We want to limit or avoid ultra processed foods. When it comes to red meat, we want to limit consumption to, let's say, 12 to 18 ounces a week. We want to eat a varied diet that's rich in plants and fiber. That's going to help decrease your risk of developing breast cancer and other cancers, and it's going to help you achieve that goal of avoiding obesity. So the other big thing is avoiding or limiting alcohol. I know that I am bursting everybody's bubble right now because I just told you you can't have your charcuterie board with your processed meats and you can't have your Aperol spritz on the patio, and we're just getting into the nice weather. But if you choose to drink, let's keep it under 2 to 3 drinks a week. And I always say a glass, not a glass. You know, dose matters. We know that alcohol is a known carcinogen, and we want to make sure that we are reducing our lifestyle risk wherever we can. Another thing I put into here is breastfeeding. Breastfeeding is a modifiable risk factor. If you are able to breastfeed, it's a great thing to do for your baby, and it does decrease your risk. So there are things that we could do in our everyday lives that can decrease our risk. Some things that are not on here are, supplements. There's no supplement that shows that it's going to decrease your breast cancer risk. Um, I'm going to go into some more controversial topics in the next slide because you go online and there's a million things kind of coming at you. Everything causes cancer, everything prevents cancer. It's really hard to say, what's the evidence? What are we looking at and what really should we do? So some of the hotter topics that come up a lot when I'm talking to women about breast cancer risk, number one thing is deodorant. Is it okay to use aluminum deodorant or antiperspirant? There's no evidence that shows us that it increases breast cancer risk. There's actually a great New York Times article from 2021 where they interview Harold Bernstein, who is a Dana-Farber oncologist, and he, confirms what we already know, that antiperspirant does not, that we know of, cause or influence breast cancer risk. I use antiperspirant deodorant. I tell people whatever you're most comfortable with, go for it. But you don't have to make that decision based on worrying about breast cancer risk. Another thing I hear a lot is, I'm not going to eat sugar because sugar feeds cancer. Glucose feeds all of our cells. We need glucose to survive. What sugar does do in excess is it promotes obesity. So sugar in moderation, absolutely fine. Do we want to be getting more natural sugars rather than processed sugars? Absolutely. But that's another one a myth that I would wish go away. Underwire bra, I don't know where that came from, but I see it from time to time that people worry about wearing an underwire bra. No bearing on cancer risk. Coffee does not increase your risk of developing cancer. It may actually decrease, not breast cancer risk, but it may actually decrease risks of certain cancers. That's still being studied. One thing that can potentially be a cancer risk is breast implants. And there is a rare condition called a breast implant associated lymphoma. So someone with, I believe, textured implants, I'm not sure if that extends to other types of implants. Our plastic surgery colleagues are someone who would have a lot of knowledge on that. But if you have breast implants and you're worried about that, you could talk to your plastic surgeon about risk. But again, that is a rare risk that's being seen more. So what's next? Talk to your family. Sometimes you sit down with your family and say, hey, mom, or hey, dad, or hey, Aunt June, does anyone in our family have a history of breast or other cancers? And you may learn things about your family that you never knew. Or you may get reassurance that no, we may have heart disease or we may have this or that, but we don't have a family history of cancer. Getting a full family pedigree is really important to determining your risk. Talk to your primary care and gynecology caregivers. See if you need any supplemental screening based on your breast density, based on your personal family risk factors. See if you're someone who should pursue genetic counseling and testing. Consult with a specialist. I'm here. If anyone wants to come see me, give me a call. I'm happy to see you and do a risk assessment and see if you need anything. Please get your screenings. Screening for cancer is extremely important. It's our best tool for early detection. do your self-exams, get your screenings, move your body, keep alcohol to a minimum, everything else in moderation. And I listed my favorite resources right here. This is where I got a lot of this information. When I talk about latest guidelines, I'm often talking about the NCCN. And thank you. I'm going to stop sharing right now and go to the chat. So I got a question here that says, should everyone take this assessment and ask for an MRI? So everybody with a family history or risk factors or personal history should get a risk assessment. It's easy enough to do, takes a few minutes, and that'll let you know if you meet or exceed that 20% lifetime risk where you're someone who would need an annual screening MRI, or if you have extremely dense breast tissue, then that is an independent risk factor, and you should be talking to whoever orders your breast imaging whether or not it's appropriate you to start getting a screening breast MRI. Take a look here. All right, if you have any additional questions, please put them into the chat. I'll just wait for another second, see if there's any additional questions. All right. Estrogen dominance and modifiable risk factors to reduce it. Let's see. Someone is asking about modifiable risk factors to reduce estrogen. That estrogen is not my area of expertise. You would want to talk with your gynecologist to see if you, or an endocrinologist to see if there is a hormonal imbalance that needs to be modified or changed. We want to, with our higher risk women, we want to have a very much in-depth and risk stratified conversation if they're looking into any sort of hormone replacement therapy or hormone management. I have another question here that's saying, what should you tell your doctor if they don't recommend breast exams? Tell them that the NCCN guidelines, the national guidelines, let us know that self-breast awareness and clinical breast exam is recommended even for average risk women. So being aware of your own breasts and having a clinical breast exam is recommended even for average risk women. Someone is asking about soy. This is another kind of common myth. Normal Western dietary intake of soy does not increase your risk of breast cancer, and it is an excellent source of plant-based protein. So enjoy your tofu. Someone is saying that they are a 2-time survivor and currently taking tamoxifens. Any other suggestions or advice for prevention? So for prevention, it's lifestyle and following your plan for survivorship. Taking risk-reducing medication, making sure you're maintaining a healthy body weight, healthy diet, exercise, alcohol to a minimum, and keeping up to date with your exams and screenings. I always tell people, because especially someone who's been through this, sometimes you're waiting for the other shoe to drop. And I say you could control what you could control. So there's a lot out of our control. And what we do is we take what we can and we take our lifestyle changes and we do the best. And in all likelihood, I'm going to be, maybe I'll see someone like, I have people that I see that are 25-year survivors, and I always celebrate that. So every milestone is something to be celebrated. Just going to stay on for just any additional questions. All right. Excellent. Thank you very much, everybody. You could do, contact your primary care gynecologist or specialist providers if you have any additional questions. I hope this was helpful and informative. Thank you.